Assalamu alaikum. We are starting this session with Mr. Ahmed. He's 30 years present with fever for the last 15 days. We'll start after the timer will be shared. Okay, you can see the timer now?
Yeah.
Let's go. Start, please.
Hello. My name is Dr. Mustafa. I am one of the doctors here. May I confirm this is Dr. Ahmed, 30 years? Hello.
Yes, I am.
Okay. Mr. Ahmed, I'm here to take history and examine you. Is that all right?
Yes, please, doctor.
It came to my knowledge, Mr. Ahmed, that you are having a high temperature. Can you tell me more about that?
Yes, doctor. Actually, I have high body temperature since 15 days. It start gradual, but now is increased, doctor.
Okay, and is there any shaking or rigors?
Yes, doctor, sometime.
Okay, do you feel night to my voice?
Your voice is interrupted.
Okay, is there any night sweats?
No, doctor.
Okay, so do you feel any headache?
No.
You told me about this high temperature. Is it something continuous all over the day or
Yes.
worse in part of the day?
Yes, doctor, in all the day.
Okay. Do you notice anything that worsen it?
No, doctor.
Hello? Okay.
No, doctor.
Please, the answer is taking long. Okay. So what did you do to help this fever when it comes?
Yes, doctor, just only a painkiller.
Okay. Any other before, did you have this fever before?
No, doctor, it's the first time.
Okay. Did you have any recent travel or
No,
last
doctor.
3 months? Okay.
No, doctor.
Did you have any contact with a person with fever?
No, doctor.
Okay. Any okay. So any cough, Mr. Ahmed?
No.
Okay. Did you feel any sore throat?
No.
Any body ache or tiredness?
No, doctor.
Okay. Any so you did you have any weight changes?
No, doctor.
Okay. Any shortness of breath?
Yes, doctor.
Okay. Did it start with the fever or
Yes,
when did it start?
Yes, the start the same period.
Okay. And is it getting worse?
Yes, doctor.
What shortness? Okay. Is there any wheezy?
No.
Whistling sound. Okay. Was this shortness of breath is worse when you walk?
Yes, doctor. Increase when
And
I go back.
go back? What do you mean go back?
You mean increase when I walking, when I do
Walking.
exercise.
Okay. Is it worse when you lie down flat in the bed?
Yes, doctor, sometime.
Sometimes. Okay. Do you wake up at night, Mr. Ahmed, want to breathe air?
No.
Okay. Do you have any sort of cough? Oh, you told me you don't have. Okay. So this shortness of breath is worse all over the time, or is it intermittent?
In all over the time.
All over the time.
Mhm.
Okay. Did you have the shortness of breath before?
No, doctor.
Okay. Okay. Can you tell me, did you have any cough of blood?
No, doctor.
Okay. Do you have any problems before with the lungs or chest?
No, doctor.
Okay. So any I want to ask you any feeling of sickness or nausea?
No, doctor.
Any tummy pain or
No.
fullness? Okay.
No, doctor.
Do you have any skin rash or discoloration, I mean?
No, doctor.
Okay. Any joint pains, Mr. Ahmed?
No, doctor.
Okay. So you have shortness of breath and fever. Okay. And any problem with the urine?
Yes,
I
doctor.
mean,
Yes.
yeah.
Recently, I noted it's become changing in color. It's become more dark.
More dark. Is it tea-like or cola-like?
Yes, doctor.
Okay. Is that when do you mean when recent?
The
Started?
same period. Yeah, the same period.
The same period. Okay. Is it something all over the or beginning when you go to the toilet?
In all
Sorry, Mr. Ahmed, for that question. Okay. In all the urine, any pain when you exert in the urine?
no.
Okay. Any other discoloration? I mean, cloudy color?
No, doctor.
No burning?
No burning, doctor. But I
How-
noted
yeah.
this is decrease in amount also.
Decrease in amount. Okay.
Mhm.
You didn't have such problem before.
No.
Okay. Okay. Any clots?
No.
Any pain in the side of the tummy
No.
or the back?
No.
Any back pain? Okay. Did you have brief? Oh yeah. Did you see any gravels in the urine?
No.
Okay. Mr. Ahmed, do you have a long-term relationship?
No, doctor.
Any previous? I'm sorry for the question. Sensitive. Is there any before? Do you have any relationships?
No, doctor.
Okay. And any needling, needle sharing?
Yes, doctor.
Okay. Is that how many times?
Since long time, doctor.
Long time. And are they known of any diseases?
No.
Okay. And when is the last time?
In the last 1 month.
Last summer. Okay. Can you remember when that started? The first one?
It started since 1 years back.
1 year back. Okay.
Mhm.
Any blood transfusions, Mr. Ahmed? Did any
No.
give you blood or okay? Any IV use? I'm sorry for the question.
Yes, doctor. I use some.
Blood. Yeah. Yeah.
I use some IV medication by IV injection.
Okay. What medications? Do you know the name?
I don't know the name.
Okay.
Like
Like what?
something for the mood, doctor. like heroin, like something like that.
Okay. Did anybody tell you your eyes are yellowish more yellow or anything like that, or skin?
No.
Okay. Do you have any lumps or bumps in the body?
No.
Okay. Okay. Do you have any past history of medical condition should be aware of?
No.
Okay. And any surgeries before?
No, doctor.
Do you have? What do you do for a living, Mr. Ahmed?
I work in. I am still study.
Okay. How is your study? Do you find your level as well,
Yes.
or is there any problem?
Yes, doctor, as well.
Is this illness impacting you? How much?
So much, doctor, because I'm since 15 days, I have a fever. I can't go out.
Okay. We will do our best to help you with that, okay? And if you require any help, we may inquire from the social worker. Is that all right? If anything
Yes,
related to the study. Okay.
Thank you, doctor.
Can you tell me if you take any medications regularly?
No.
Okay. So apart from the medications you told me, do you take anything else over the counter?
Doctor. No, doctor.
Any okay. So I want to ask you, Mr. Ahmed, do you feel any palpitations or feeling of your heartbeat?
Yes, doctor. Recently, I feel awareness of the heartbeat.
Can you describe me that? Is it
yes,
regular?
Yes, it's regular, but I think, doctor, is fast.
Fast. Do you feel any kind of faint or about to faint with that?
No.
And how long does it last, these episodes?
2 and 3 minutes.
Okay. Okay. Any swelling in the legs?
Yes, doctor. Recently, my leg has become more swollen.
Okay. I want to start examination. So I will look in the hand for clubbing, for splinter hemorrhage.
Yes, there's clubbing and there's splinter hemorrhage.
Okay. Osler knots, genuine lesions.
Yes.
Any? Okay. And I will check for pallor in the eyes and jaundice.
There's mild pallor, but there's no jaundice.
Mild pallor. Okay. Any red eye?
No, there's no redness in the eye.
I will offer fundoscopy. I would like to offer fundoscopy.
For what?
Fundoscopy. For rough spots. Okay.
There's okay.
Okay. I will check palpable
2
lymph
minutes
nodes.
remaining.
Cervical.
There's no lymph node.
Okay.
There's no lymph node.
Auscultate for the heart, first and second heart sound.
There's tachycardia.
Yeah, tachycardia. The vitals are the same as, how's the vitals?
The vital temperature is the 39, blood pressure 100/60. The pulse is 90.
90.
90
okay, I will offer antipyretic at the moment, and I will check the pulse. How is it? Volume, regular, or
yes,
not?
It's regular with a good volume.
Good volume, synchronous.
Yes.
Okay. I will listen to any murmurs back to the heart.
Yes, there's murmur in tricuspid area.
Okay. Band systolic or what?
1 minute
yes,
remaining.
band systolic murmur into the tricuspid area.
Okay. Basal crackles, features of heart failure, basal crackles, and lower limb swelling.
Yes, they're fine. Then fine basal crackle into the lung.
Okay. And what is your concern, Mr. Ahmed?
Doctor, I want to know what I have.
Yeah, I will check if any discoloration or lesions quickly. No discoloration or rash?
There's no rash.
Okay. I would like to complete. Okay, Mr. Ahmed. Any? Well, I should check the splenomegaly if I have time.
Yes, there's splenomegaly, mild
Okay.
splenomegaly.
Mr. Ahmed, actually, it appears that you have something related to infection to the heart. I'm sorry for telling you that. We will involve the heart doctors and we will do further scans. And we need to give you medications. You need to be admitted and to be receiving antibiotics. We need, that's more likely related to the, I'm sorry for telling you that, but you are taking a risky lifestyle and we need to first manage your medical condition.
Is it serious, doctor?
Yes, it is something serious but treatable. You need to be admitted and you need to receive prolonged, like long time antibiotics through the channels in the vein, in the blood.
Okay, time is up.
Yeah, yeah.
1 minute I added for the consent. Now you can go to examiner time. Present to your case to Dr. Rasha.
So, yeah, Mr. Ahmed is 30 years old male with a subacute history of fever, shortness of breath, palpitations, and evidence of symptoms of heart failure and clinical signs. He has shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, and he has peripheral, he has stigmata of infective endocarditis. On examination, it appears that he is in heart failure and also anemic. He is febrile. He is vitally stable at the moment with borderline blood pressure, borderline low. I need to complete my examination to check if he has evidence of signs of pulmonary hypertension. I would like to do a urine dipstick and I will offer a rectal examination. If reason of his anemia else. He has IV drug use of unknown name of medication and needle sharing, and that's strongly suspected to be the reason of his symptoms. He should have been
Dr. Abdullah.
my differential. Yeah.
Yeah. 2 minutes is enough for the presentation. Yeah, Dr. Rasha, the next question.
Yes. Okay. What are the stigmata of infective endocarditis presented in this patient?
Sure. So, starting from periphery, he has clubbing. There is the ischemic stigmata, which is the splinter hemorrhage in the periphery indicating ischemia, and also Osler nodes, which are painful lesions in the periphery. Also, there is the inflammatory stigmata, which I mean Janeway lesions, which are painless lesions.
Can you just decide it for neurological phenomena and vascular phenomena? What is the vascular phenomena
yeah.
is presented in this patient?
Okay. I'm not sure in this patient I'm not sure of the vascular phenomena.
Mm-hmm. Okay. What is the criteria for diagnosis infective endocarditis?
So it requires clinical suspicion, and then with evidence of on echocardiogram.
Mm-hmm. And
That's like typical of vegetation to confirm the echo around the valves, and also positive blood cultures.
yes.
That is
What is the criteria of a blood culture for diagnosis
yeah,
infective
blood
endocarditis?
culture should be taken on separate time, 2 over 12 hours separate, or could be more than that.
Okay, what
I'm not
investigation
sure.
you wanted to do?
Yeah, he should have also inflammatory markers. So starting from, he should have inflammatory markers along the baseline investigations. Inflammatory markers, I mean ESR, CRP, and also he should have a confirming of anemia, and looking in his whole white blood cell count and platelets and renal and liver function tests. He should have also he should have
what are indication of the surgery of the infective endocarditis?
He should have, sorry? Oh, indications of surgery are okay. Non-resolving persistence of infective endocarditis despite full-term duration of medical treatment with suitable antibiotics, and a large vegetation and also abscess formed.
Okay, how can what is the simple investigation do to confirm the aortic abscess?
ECG can give a clue about that.
For what?
But
what did you show?
A prolonged BR interval.
Mm-hmm.
I'm not sure else.
Yes. What is the most common common organism?
Yeah. The common organism depends if the patient either post-surgical or the commonest organism otherwise is
regarding this patient.
Okay, regarding this patient, I should suspect Staphylococcus epidermidis.
Mm-hmm. IV patient, IV drug abuser patient.
Yeah.
Mm-hmm.
I think I'm not sure, but gram-positive cocci.
Mm-hmm.
Yeah.
Okay. How can manage?
Okay. According to the so there is empirical antibiotic regimen. Well, he should be first managed by supporting his condition by IV antibiotics, and we can give according empirical antibiotic. We may combine
systematic.
Yeah.
Start systematic. What we are always practicing, do it. Are we starting with the pharmacological?
No, but this patient could be not stable. So to discuss of education still, I don't know. So first educate the patient about his condition, counseling, we will inform a multidisciplinary team approach, starting from specialized nurse and also a cardiac team, including cardiac consultant, and we need to indicate here microbiology importance, that to give suitable antibiotic initially empirically until the culture results. Yeah.
Okay. What indication of a prophylaxis on the infective endocarditis?
Indications of prophylaxis. Yeah. So if the patient has in some cases of not fully corrected congenital heart diseases, before procedures, surgical procedures, if the patient has non-corrected congenital heart disease, and if the patient has in some patients of hypertrophic obstructive cardiomyopathy, I think. I'm not sure about that.
What the antibiotic is given?
For prophylaxis? I'm not sure.
Okay.
Okay, the differential, Dr. Abdullah, I didn't mention the differential. Sorry, Dr.
She
Rashid.
didn't ask. She didn't ask. The differential diagnosis is I should include the IV. So first, on top of differential infective endocarditis, second, I think of hepatitis B virus and hepatitis C virus and HIV. Yeah, that's my differential.
Opportunistic infection, do you think you can put an opportunistic infection?
Yeah, opportunistic infection is HIV positive.
BCB?
So fungal infections,
Cough,
to do,
exercise, BCB, pneumonia?
pneumonia,
pneumonia, brucellosis, TB.
Okay, so you're done, Dr. Abdullah, right? Dr. Rasha? It's 11 minute now examination or examiner time. So let's start comment by Dr. Rasha, then I will comment. Start, please,
Yes,
Dr. Rasha.
overall well done, دكتور عبد الله. بس في شوية some of point missed. The first of all, the temperature, the onset والcourse والduration, the measure. How to measure the temperature? How much? This the patient pyrexia with unknown origin, يعني fever with unknown origin. You must exclude the other symptom. The cough is okay. Ask about the cough, the pneumonia, hemoptysis, sore throat. Is it okay? GIT, ask about the jaundice and ask about any tummy pain or tummy distension. But you didn't ask about any the CNS symptom like confusion, neck stiffness. Also ask about the headache. A CNS symptom for meningitis and encephalitis because the patient presented with the fever. The second CNS symptom is important because the infective endocarditis may be causing systemic immobilization, emboli.
Yes.
Weakness, mouth deviation, offer to full neurological examination. Then after that, ask about the dyspnea, chest pain, ask about orthopnea, and then ask about the leg swelling. Then ask the urine for hematuria and for anuria. And also ask me 2 questions. Ask me about if there's any throwing up and nausea. Yes. And also ask me about the travel history, but you don't ask me about the animal contact because the patient may be brucellosis. Ask about the weight and neck swelling, lump or bump to rule out any tumor. You did ask me about any joint pain, any skin rash to the sun exposed area to rule out any connective tissue disorder.
Exactly.
Okay. Ask me about الباست medical والباست surgery. Don't ask me about unpasteurization milk to rule out brucellosis and a patient جاب splenomegaly and high grade fever. Okay. Regarding yes, regarding the examination, it was normal. Okay. الكلابينج والأوسلر وجوان واي الهارت for any murmur S1 and S2. Offer to the fundoscopy to see any rough spot. And offer to the CNS examination. Yes, but I want to answer the questions asked. The prophylaxis for infective endocarditis given for the patient, if patient high risk previous history of infective endocarditis, or the patient have a transplant heart or congenital heart disease. Antibiotic, amoxicillin 1 hour before the surgery if the patient has allergy. Amoxicillin given clindamycin.
Nice.
Yes, for the patient, IV drug abuser is the most important, the most common organism, staphylococcal. This Staphylococcus aureus.
I totally forgot the name. Okay,
Staphylococcus epidermidis, after the patient do the surgery, within the 2 months, the Staphylococcus epidermidis is the risk.
Yes, yes.
Regarding the criteria for the patient to rule out for indication for the surgery, if the patient symptom of heart failure does not respond to the treatment, medical treatment, or patient persistent fungal or bacterial infection, patient under systemic immobilization, patient aortic root abscess is important في infective endocarditis, ECG for prolonged BR interval.
Can you repeat that? Sorry.
For the patient, indication for the surgery, patient for heart failure not responsive to the medical treatment, patient resistance to the medical treatment, fungal infection, systemic immobilization, aortic root abscess is important for the patient infective endocarditis to do ECG to show any AV block, and for the second for prolonged BR interval.
Okay.
الفاسكولار فينومينا الرايثر سبوت والاوسلر ويف والكدني افكشن.
Rose spots.
spot yes, والكدني الجيومونوفرايتس الجي ان لا اله الا الله شنو الاخرى الفاسكولار يس الرايثر سبوت والاوسلر
وروث
والكدني والاي.
يس
الاذر سيمبتوم كلهن immunity.
Don't worry, Dr. Ihda. We will repeat all these things.
Yes,
Dr. Ihda asked to slow manner.
Yes, الامبورتنت الامبورتنت ECG والايكو. الموست important transesophageal echo diagnosis 95%, transthoracic 75%, والESR والCRB والblood culture different side, different blood vessel, different time.
Okay.
التريتمنت الامبيريكال تريتمنت الاموكسيسيلين والجنتاميسين. if the patient allergy للاموكسيسيلين vancomycin. if the patient valve replacement vancomycin, gentamicin and rifampicin C. Okay.
Yes. For how long, or you're not sure?
For how long? For what?
The duration, antibiotic.
I think for 6 weeks.
Okay. Nice, nice. Thank you so much. Good explanation. Thank you.
Welcome.
Yeah, the antibiotics, Dr. Rasha, again, Fajr.
I think for 6 weeks.
No, the name of antibiotic, Fajr.
Amoxicillin,
name,
No,
gentamicin.
this is
names, yes.
Dr. Abdullah. This is
Allergy.
prophylactic. The amoxicillin for prophylactic. I'm asking about the medication, antibiotics treatment. Yeah,
For
Fajr,
treatment, empirical,
yeah.
yes. Fajr for a Fajr for a prosthetic valve.
Yeah. Yes, this is for the
Gentamicin,
prosthetic.
rifampicin, or vancomycin.
Yes, this is for prosthetic patient or prosthetic valve. Okay, if
Yes.
native
If
valve,
empirical, amoxicillin and gentamicin.
yes,
If the patient allergy للأموكسيسيلين, vancomycin and low dose of
gentamicin.
gentamicin.
Yes. Okay. Are you done,
Yes,
Dr.
I'm
Rasha?
finished. Yes.
Thank you for this case. It's a very common topic in the exam, either in the cardiac or station, or a short station of the heart, or in the long station. So it's very important topic. Well done, Dr. Abdullah. However,
you.
you missed some. Yeah, you missed some points. I will tell you.
Yeah, sure.
It's very in the temperature. Before starting, I don't know why you start immediately. You should take time to think about or to prepare the case, because fever is a major complaint, and as Dr. Rasha said, the fever for of unknown origin, it's a major topic, and you should think about the possible system might be affected, either meningitis, CSF, or chest infection, or UTI, or blood, like in this patient, infective endocarditis, or gastroenteritis. This is the most common system will be affected by temperature, or constitutional, or hemorrhagic infection, or viral infection. You should think about malaria. So the analysis of the complaint, OCD, onset, course, duration, and the manner of temperature, or the high temperature. Is it cyclic? Rule out malaria is very important in this patient. How the fever is coming, either regular or cyclic manner, or continuous. Okay, and how great, or how high this temperature? Is it 39 and high, or just low grade? It also give you a clue. Okay. Then, yeah, you ask a good question about rigors, the association with the common association with the fever. It's rigors or chills. It's important as well. Any previous attack. Then the constitutional symptoms. You can ask immediately about constitutional symptoms to rule out or to rule in serious infection. In such patients, if you ask about his weight, his appetite, I guess it will be affected. Jaundice, tiredness, lumps or bumps, and night sweats. So you have a serious infection like this patient. You can ask for the previous medical history if you suspect immunocompromised patient, or lymphoma patient, or patient with long-standing disease. But anyway, you discover that this patient is having HIV from the manner of the risk habit. He has risky habit, which is drug abuse. Then I will ask you what to ask in the drug abuse. You ask here what the medication. It's called drug. It's not medication. So what you are using, what drug you are using. It's not medication. Okay. This is the term. Yeah, a term in places and in Europe. Drug means abuse. Medication means prescribed by pharmacist or by doctor. So the drug which are using in abuse, or party, or recreational, it's called drugs. So don't say medication, because the medication will never be abused. The drug, the one will be abused. So what are you using and how you are using? She told you that I'm sharing needles. And so, what's the last time you shared needles? What last time you shared the needles? And what was the medication? Yes, as you said, and as you asked, this is a perfect question for the sharing needles. You can, in the same time, you can ask other risky habits. Do you have any tattooing? Do you have any piercing? Do you transfuse blood before, or you received blood transfusion before? And the casual relationships to confirm that he is HIV. Okay. Travel history, you did great when you ask about travel history. He might or she might or he might be infected by either malaria, can be as a travel history, brucellosis, as Dr. Rasha said, in the travel history, any pasteurized milk, any contact with sick patient, as you did. The medical history, surgical history, allergy, very important. You ask about the allergy because you might start him on antibiotics. So it's important to ask about the allergy. Family history of same condition or family history of roll out or roll in. If there is family history also affected, might be like food poisoning or gastroenteritis. Let's go to the system review. I will be quick. You ask for the chest. Yes, there is cough and fever, cough and short of breath while walking. It's a clue. When you have short of breath while walking, think about BCV pneumonia. It's very important. And then any sore throat, you ask good question. GI, feeling sick or any tummy pain. Cardiovascular, lately you ask about palpitation. And it was also conclusive for infective endocarditis affecting the tricuspid valve. Irregular heartbeat, yes, good question you ask. The lip swelling and genitourinary you ask. Dark urine, decrease amount, joint pain and skin rash you covered. You forget to ask about female history. Any change in the period? Sorry for this question, or any miscarriage or whatever. Job, you ask about the job. Sorry.
هو ميل يا دكتور.
Oh, sorry. Okay, Ahmed. Yes, you're right. Sorry. Okay. The job you asked, but you missed
Yeah,
the smoking and alcohol.
he's a
Yes.
student. Oh, I forgot the smoking and alcohol.
Yes. Always remember these stuff together. Do you smoke? Do you drink alcohol? What's your job? Do you drive? Do you drive? Do you smoke? Do you drink alcohol? What's your job? This package together. Okay, and the social together, family, travel, medical, HIV. Fatma, I mentioned all of this. I am trying again to remind. Fatma, Fatma means F for family, T for travel, M for medical, and H for HIV. And the occupational, do you smoke? Do you drink alcohol? Do you drive? And what's your job? Okay, this is how to remember these things without missing any point. The examination, you were late in the examination. You took long for the history. That's why you were late. You did the examination at the last 2 minutes. And in such patient, you will find a lot of things, starting from the hand, clubbing and genuine lesion, splinter, hemorrhage, osseous nodule, and pallor. You might examine the pulse, any palpitation or any, sorry, arrhythmia. You might have AF, and if you have also aortic affection, you might have collapsing valve. Then injection mark is very important. You missed here in the arm or in the cubital fossa. Any injection mark, you should do it. You know the case. It's HIV due to injection or drug abuse. So check for the injection mark. Vasculitis should be excluded. Yes, vasculitis affection. We said osseous nodule, one of the immunological, and the splinter hemorrhage. Yes, we should do it in the hand. Okay, the blood pressure, sitting and standing, rule out any postural hypotension, and the blood sugar as well as vitals. Try to remember vitals, and you will find the four things. Temperature, it's the main complaint. you should offer. You did it. You ask for the temperature and you offer antipyretic. So the temperature, the blood pressure, the heart rate, and the blood sugar. This is for the vitals. What common causes of... Okay, we'll come to the question later. Let's finish the examination. Then the neck, for the neck veins, congested neck veins, you will find positive congestion or raised GVP. Then the face, for the pallor jaundice in the eye.
I didn't do jugular. I forgot it actually.
Yeah. Be systematic in this way. You are going from the hand upward toward the neck, then the face. You will remember every step if you do like that. You start by the hand. First thing to hold in the patient or to hold in the examination, the hand. Going up the arm, blood pressure, injection mark, going up the neck. You will have the neck, congested or raised GVP, then the face and the mouth. Open your mouth, offer fundoscopy for the Roth-Stott. Back to the neck, examine for lymph nodes as you did. Then the chest, scars for any scars for valve replacement or any scar in the chest. Then the heart more important than the chest. Start by the heart. S1, S2, as you said, apex detection, displaced or no. Any murmur, start auscultate the murmurs. Any murmurs over the mitral regurg or tricuspid, you will have tricuspid regurg because this is right side affection. Then parasternal heave. In the same time you are examining the valves, go to the Blaued B2 parasternal heave. Then finish the heart murmurs. Go to the back for fine basal crackles if there is heart failure signs. Finished, you go to the abdomen for splenomegaly or palatable kidneys if there is any kidney affection, and down to the legs for leg swelling or edema, I mean. This is how to do this case. The differential is very important in this patient. You think first top of differential is infective endocarditis, then opportunistic infection due to HIV, then other opportunistic infection again due to HIV, fungal or whatever the reason of the infection. This is our case. I think Dr. Rasha covered the topic of HIV, sorry, infective endocarditis in scientific way. I mean, let's talk about the treatment. Whenever you have patient in acute state, start with ABCD. This patient, he's not in, he was in failure, right? He's in failure, so you can say that ABCD approach. Patient in failure, I will admit him, and I will start ABCD approach. Then multidisciplinary team approach. Any case in the exam, you should do a multidisciplinary team approach. Don't tell me I will start with pharmacological because it's infective endocarditis. Yes, you will do, but you will call also ID, infectious disease. You will start antibiotics by yourself, or you will have opinion from the ID to start proper antibiotics. Maybe the patient is allergic to some medication. So again, the multidisciplinary team is the best choice. Okay. What the team you will call? Cardiology and infectious disease, pulmonology, there is also chest symptoms, nephrology, because also you have some genitourinary, and specialized nursery and GP. Ophthalmology if there is those spots. Okay. And then non-pharmacological and pharmacological. Any patient, even he is in acute state, you will start by this way. After ABCD approach, of course, and admission, you will tell him in this way. Don't tell him pharmacological. Okay, tell me the pharmacological. You might go to the pharmacological and the antibiotics, and you will be more squeezed in the antibiotics, and he will tell you, give me the option if the patient is a native valve. No, if he is a prosthetic valve. And you might mention wrong antibiotics. So try to be smart. Answer with the stepwise manner, and to get full mark, he will think that you are smart and very safe doctor because you didn't do everything alone. Okay, let's go back to the patient non-pharmacological patient education counseling about the condition. Very important here, and during the history taking, please try not to share needles with others. As one of the colleague shared with us, there is a program called Safe Needle Sharing, or I forget what she mentioned, but it was how to share, how to use safe and clean needles. It's a program in Europe. I'll try to recall it. Anyway, so whenever you have something risky for the patient, immediately advise the patient about, please try to avoid sharing needles because it's harmful for you and your health. We care about you, and if you need help, we can help you in this. Okay, we have a perfect team. Even you don't name the team, but we have perfect team. He can help you in this regards. Okay, let's go ahead with the other patient education counseling about the complication association and how to prevent the further infection. And very important here to counsel him about HIV. You might have HIV, and we will have screening for HIV. It's very important. You should get a verbal consent. Actually, we suspect that you have HIV, and we should do screening for HIV after your acceptance. Okay. Then the pharmacological. You can do whatever, and you can say whatever you want to say in the pharmacological. You want to say antibiotic, okay, infection, antibiotics, the indication for surgery, whatever you want to say, you can do it. But if you have time. Investigation, we didn't say the investigation. Let's start from the baseline, basic workup. CBC, inflammatory markers, kidney function, liver function, coagulation profile, ECG, very important, echo, fundoscopy. What else? Yeah, blood culture is very important here, specific for the 12 hours apart, and they do it peripherally. Then we'll start antibiotics after the culture. You can do urine dipstick for the affection of the kidney and blood sugar, or if the patient have any comorbidity. And HIV screening is very important in these patients. I hope we covered this topic well. Dr. Ihda, yes, Dr. Thank you so much, Dr. Needle exchange services, needle exchange service. This service is concerned to helping the patient to use a needle or a safe and clean needle. Even he want to do the abuse, it's okay. He can do, but with a clean needle without sharing. So he will have less risk of infection. Yes, thank you, Dr. Ihda. And he will be safe from infecting others, and he will be safe from contracting another infection. Okay, so remember this one, needle exchange services, what they are and how to use it. One, yes, it's this program concerned to the people who are drug abuse, and the aim is to use clean and safe needle by themselves without sharing it with others. This is the program aim. Okay. What the common cause of pyrexia of unknown origin in patients? Yes, as I said, there is 4 system might be affected, starting from up CNS. So what's the CNS could be infection there? It's meningoencephalitis or encephalitis, according to the age, according to the presentation, according to the finding. Neck stiffness or behavior change. So you should suspect either meningoencephalitis or encephalitis. Brain abscess can be, but I didn't hear about brain abscess in cases, but it's one of the infection of CNS. Okay, what other system? Going down, we'll go to the chest. So chest infection. You have a lot of the chest infection bases. Legionella in traveler person or traveler patient. You have also TB as a sick contact with the sick people in travel, India or endemic area. BCB, one of the common scenario in the exam, BCB, pneumonia, either on top of HIV or on top of immunocompromised medication like methotrexate or chemotherapy. This is another common topic for the chest. Other chest could be COPD and bronchiectasis. This is the infection. Okay. The next will be the GI, gastroenteritis, traveler diarrhea, or any diarrhea in the places common like traveler, E. coli, and Shigella as food poisoning. What else as gastroenteritis? Amoeba, amoebiasis, Campylobacter. This is the common GI infection or gastroenteritis. Then the UTI. This is the last system will be infected. UTI. So UTI, I think it's clear UTI, maybe due to indwelling catheter or due to reflux in younger patient. The last system will be infected is blood, as in this patient infective endocarditis. The blood system, bacteremia or sepsis. Infective endocarditis, one of the most common, and never ever station in the heart pass without taking you to this topic. Any case with any either valve replacement or regurg, even without replacement, the examiner will take you to this point. He will ask you about infective endocarditis. All our colleagues underwent exam. They were asked about infective endocarditis. Any question, imagine, either surgical indication, as Dr. Rasha said, or the pharmacological or the prophylactic, any question you could be asked about infective endocarditis in the heart station. So be ready to read this topic, whatever you are going, or whenever you are, or wherever you are going. Infective endocarditis is a very important topic in the PACES exam, either as long or in the heart station or the cardiac station. Even normal examination or even no valve replacement, they might take you to this topic. It's very important. I am repeating because it's very important. Okay. Let's have another, Clostridium difficile. Yes, a very important topic. Yes. Thank you. Clostridium difficile as an infection in the hospital acquired one, or after antibiotics exposure. I think now Staph aureus is the most common cause of overall. Then Streptococcus viridans. Yes, Staph aureus, especially those who are drug abuse, because it's a normal organism or flora of the skin. Viridans coming if no drug abuse. Okay. Staph epidermidis after surgery. If the patient has surgery for any reason. I mean, if the patient has surgery for dental or any reason, colonoscopy or surgery for the bowel, but after 2 months, within 2 months, the epidermidis will be the top of causes of infective endocarditis. After 2 months, the Staph aureus will be the predominant again. Is that clear? We talk long about this topic. When to start empirical antibiotics and when to wait culture result. If you suspect, you should start. No wait. Whenever you suspect infective endocarditis, you should do the culture, withdraw the culture, and start immediately with the antibiotics. Okay, the drawbacks of infective endocarditis, if you don't start, will be more serious if you start late. This is the policy for any hospital worldwide. When you suspect, withdraw your culture and start immediately the antibiotics. Empirical and wait for the culture and downgrade or de-escalate according to the culture result. Any question? Any comment? Thank you, Dr. Rasha, for the case. And sorry for lengthy talking about this topic, but again, it's a very important topic. either long or short station. Okay.
Can I say one comment?
Yeah, sure, Dr. Sarah, right?
أيوة بالظبط.
Okay, sure.
for the
Yes,
plenary team, we are not involving the GP in the hospital setting. The GP only we involving him when the patient will be discharged and he can follow him for any investigation or any blood, because this is another institute. And regarding the antibiotic, we won't say the name of antibiotic. We can say we will start an antibiotic according to the hospital guidelines, because every hospital has a
excellent.
guideline for antibiotic. So it will be like,
Excellent.
and they are not caring about the name of antibiotic or which
Really?
antibiotic.
Thank you.
Yes, because this is
Reassuring. Thank you.
according to the hospital guidelines. And the issue also, we should discuss with the microbiology that you are right, that we should involve the infectious team or the microbiology team regarding which antibiotic we should start with.
Excellent.
Okay.
Thank you, Dr. Sarah. You reassure us. Because I
Yes.
have problem with remembering the name of antibiotic. Some
No.
mnemonic like Fajr and Jar and whatever the name.
No,
But
we usually antibiotic, but yes, according to the
yes,
culture, but the empirical antibiotic it will be according to the hospital guideline after discuss it with the microbiology team, because the microbiology, when you discuss it with them, they can check from before the previous culture for this patient, and if it's UTI, they will see patient maybe have previous UTI and it was this organism E. coli, for example, and it is
excellent.
susceptible to that. So the microbiology team will have a role in that. So we'll discuss it with them before starting the antibiotic, but we should withdraw the culture first.
Excellent. Yes, I agree. Okay, so this is a very important point to be smart while talking about the treatment.
Yes.
Be smart, yes, as Dr. Sarah said. Just mention the guidelines of the hospital. No need to mention antibiotic. You can say that and safely you can get the mark. We will
Yes.
involve the infectious disease and we will start antibiotic according to the policy or guidelines of the hospital. And this is real, what we are doing. This is the real.
Yes.
So, yeah, instead of mentioning antibiotics, and it might be wrong, and maybe the examiner doesn't care about the name of antibiotic, he doesn't know it.
Yes.
And if you say, yes, yes, please, Dr. Sarah. Hello? Dr. Sarah?
Hello.
Okay.
Yes. Yes. Thank you.
Yeah, maybe he doesn't want you to mention antibiotics. If you said this, definitely the answer will be correct. If you
Yes.
say,
Any doctor
yeah,
could say the antibiotic. Usually, is when we are prescribing any antibiotic for any patient, they tell us check the hospital guidelines. So every
excellent, yes,
hospital has its own guidelines. So we're checking the hospital guideline, discussed with the microbiology, and then we'll prescribe the antibiotic.
excellent. Okay. Thank you, Dr. Sarah, for your share. And let me also add, yeah, I want to answer your point regarding GP. Yeah, sometimes we include the GP if we will treat the patient and he will be having follow-up with his GP. This is
Yes.
what I mean by GP in the team.
Yes. Yes.
So in
Because
such patients, because
is
always
yes.
the patient referred from the GP. So I will involve the GP about the plan and the management in the
Yes.
future. That's why we are mentioning him.
Yes. 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 You're right.
You agree now?
We
Okay,
are
thank you, Dr.
seeing the cold cases. They are not seeing any emergency case. So
Yeah,
if
yeah, yeah, I agree. But even when you discharge the acute patient
we send the,
after control,
yes, a discharge summary to the GP.
yeah, exactly. So the GP all are involved in the post-hospital plan. That's
Yes.
why we can call them. It will not harm if I say that.
Yes, yes, but the other things you need to be careful. The GP, if the patient is an HIV, some of the patient you need to take all of the patient you need to take the permission to disclose the HIV to the GP.
Yeah,
Because
yeah, I agree.
I don't want the GP to know about my HIV. So he
Agree,
has the
yes. After his approval, yes, I agree.
we could do the discharge summary without mentioning that he's HIV infection, because this
Yeah,
is one.
after his permission. Yes,
Yes, this is
I
also.
agree. Yeah, thank you, Dr. Sar. Thank you. Okay, there is question 70 female worsening balance. What is this? This is the scenario, sorry. Can we add also cancer for pyrexia unknown origin or fever for unknown? Yes, of course. There is a topic called sepsis in immunocompromised patients, bacteremia or sepsis, especially those with the Hickman or line for the chemotherapy. You suspect the blood the blood infection or bacteremia in those patients, and those patients should be started immediately on broad spectrum antibiotics. There is also guidelines and policy for those patients. Immediately, you will start after withdraw the culture from the line and peripheral. This is another topic and very important as well. Okay, I think this topic discussed a lot. Dr. Abdullah, you were saying something. Sorry for interruption. I interrupted
Thank you,
you.
Dr. Basim. Thank you so much. Actually, I was asking the mnemonic. Can you repeat it, Fajr? It's not clear to me.
Fajr vancomycin, F for vancomycin, G for gentamicin, and R for rifampicin. This is for replaced valve,
Yeah.
empirical replaced valve. Okay.
No, I mean, do you have a mnemonic for the family, smoking, alcohol, job?
Yeah, Fatma. Fatma for the social, occupational, do you? Remember question, do you? Do you smoke? Do you drink alcohol? Do you drive? And what's your job? Do you drink alcohol? Do you smoke? Do you drive? And what's your job? This is for the occupational. Remember always this four question together. Don't ask one without asking the other. All of them
Nice.
are important, okay?
Nice.
So, yeah, the driving, especially if the eye affected, is very important. If not affected and you have some musculoskeletal affection, you can ask what the impact on your driving. Is it impacting your driving? If yes, you can tell him, please, can you stop driving? This is in general, okay? But remember those package as question. Do you drive? Do you drink alcohol? Do you smoke? What's your job? And Fatma for social, F for family, T for travel, M for medical, and H for HIV, okay? I will try to mention again in the group to share it to be more beneficial. Let's go to the next case. We are so late. Dr. Rasha, are you ready?
Yes,
Yeah.
okay.
Mrs. Lisa, 70 years with worsening balance. Medication given as prophylaxis amoxicillin, thank you, 2 grams or 30 minutes before dental procedure. Also clindamycin and also, yes, clindamycin in case of penicillin allergy.
It's clindamycin of allergy, yes.
Yes.
But we are not
And
given any access before any.
exactly. Yes, exactly. It's not for any patient, only those who are indicated. Any congenital heart disease, any previous prosthetic valve, any previous infective endocarditis. Those are the common indication. Yes, Dr. Rabia, I believe that no much details, too much details, not necessary. Okay, yes, I agree with you. But sometimes we are discussing this or those things because we are not repeating the topic. But as Dr. Rabia said, in the exam, it's 5 minutes. Dr. Rasha, please prepare yourself. I will just mention this
Yes, okay.
point. Okay. There are 5 minutes. Okay. It's 5 minutes with the examiner. Try to summarize the case in 1 minute. Summarize the case in 1 minute. The differential will be in the next minute or second minute. The third minute for investigation, fifth for management. Sorry, fourth and fifth might be for management. So no time or no much time for all these details. But we are trying to collect all informations and whatever you face in the exam, I hope you will remember what we have discussed in this station. Thank you, Dr. Abi, again for your notification. Dr. Rasha, when you're ready, tell us.
Yes. Yes, I can start.
Okay, ready?
Mm-hmm.
Okay, we'll share the timer. Dr. Abdullah, are you there? Dr. Abdullah?
Yes.
Yeah, let's start this case. Seems interesting, man. Yeah, I hope so. Okay, here you go.
Hello, good evening. My name is Dr. Al-Mahdi. I am doctor in charge here today. Can I confirm I am talking to the Mrs. Lisa?
Yes.
Are you 70 years old?
Yes, I am, doctor.
Mrs. Lisa, we are here to discuss about your health status, and after that, I'll examine you and address your concern. That's okay with you? Okay. I received a letter from your GP states me that you have worsening on the balance. Can you tell me what do you meaning by worsening on the balance?
Yes, doctor, because it's literally the balance is on my legs, especially, and that's affecting me, especially even so in my walking, and also when I try to take things, it will be difficult. I can't take things. A cup of tea. Yeah.
Yes. You mean when you try to walking is fall down?
Yeah, I fell down, not every time, but it's something worsening with time. But
And also,
I feel my balance is slowly progressive.
And also when you try to pick up something, you feel abnormal movement.
Not abnormal movement. It's just like I am not able to catch the small things when I try to take them. Because of this, I feel it's a problem.
Can you tell me since how long you suffer from that?
Very long time.
Once it started, it was sudden or gradually?
No, it's very gradual, doctor.
Is it increase or decrease or the same?
Increasing.
Is it the first time or you had previous attack?
It's no, it's something continuous, long time. It's not something interrupted. It's continuous, slowly.
Okay. Do you notice any difficulty to the initiation to the movement?
No, I don't have that.
Do you notice any abnormal movement?
No, I don't have it.
Any shaking of your hand?
No.
Any headache?
No.
Any blurred vision?
No.
Any weakness?
In my legs?
In your leg or other part into your body?
Only legs.
You have weakness in both legs?
Yes. That is weakness. Balance problem also. Long time. It's becoming recent, my legs, but it's also long time. So this is like started 5 years ago, you can say, the lower limbs.
You mean started since 5 years, but now it's become more progress.
No, my leg issue, the weakness is 5 years ago, and my balance issues are since 20-30 years.
20-30 years.
Yes.
Okay. Do you notice any problem in the sensation? Any alternative to the sensation?
No.
Any problem in the speech?
Yeah, the people's telling me it's slightly looking not normal.
Not normal. What do you mean? You mean
Like low.
there's interrupted in their speech or there's slowness in
No,
their
no,
speech?
no. It's like slurry.
Okay. When you try to pick something, you feel your hand is become more shaking.
It's not. Yeah, you can say I become tremulous when I not able to take it.
Okay.
You know? Yeah.
Do you notice any loss on the water work or back passage?
Yes. Also recently I'm experiencing more of incontinence with the urine. More.
What about your mood?
It's great. No problem.
Okay. Do you notice any recently history in your memory?
No problem with that, doctor.
Any history of a trauma?
No. Oh well, yes. These issues make me fall. I fell 3 times, 2-3 times, maybe.
Okay. Any history of high body temperature?
No, doctor.
What about your weight?
Well, it's good.
What about your appetite?
No problem.
Any history of neck swelling?
No.
Any history of lump or bump to the anywhere?
No.
Any history of excessive sweat?
No.
Any history of okay, any history of fit?
No.
Abnormal movement? Any history of loss of consciousness?
No.
Any history of pins and needle sensation?
No, doctor.
Any history of double vision?
No.
Anyone comment you better than before?
No. No problem with that.
Any history of difficulty in the swallowing?
No.
Any pins and needle sensation in your face?
No.
Any history of mouth deviation?
No.
Okay. Any history of tummy pain? Any history of shortness of breath?
No.
Any history of chest pain?
No.
Any history of awareness of the heartbeat?
No problem with that.
Okay. Any history of tummy pain?
No, I don't have, doctor. Yes.
Tummy distension?
No problem with the tummy at all.
Any problem to the water work?
Yes, it is. I can't control. It's incontinent.
Since how long?
Well, also 2 years. I take
2 years.
something called. They give me medication, tolterodine, for it.
Are you complying with the medication?
I am.
Yes. After taking the medication, is improve?
No, it's difficult to improve, doctor. It's difficult.
Okay. Any history of joint pain?
No, doctor.
Any skin rash?
No.
Any medical history I should aware of?
No.
Okay. Any previous surgery?
No.
Previous admission?
Oh, the falls, the only same this condition.
Okay. Any family history with the same illness?
Yes.
Who?
The same issue. It's worse in my brother. Actually, my sister also died. Came to her really bad, the balance issues and the weakness. She was on wheelchair and she passed away.
I am sorry for that. What was diagnosis?
Well, doctor, I don't remember. I'm sorry.
Okay. Any disease runs in your family?
Yes, it looks like we have this problem. Yes.
Mhm. Okay. Show me the medication list.
Yeah, so she only takes beta histine
Uh-huh.
and
Okay.
tolterodine and baclofen.
Mhm. Okay. Sorry for asking this question. Any sharing needle?
No,
Any tattooing?
no,
Any tattooing? Any tattooing?
no.
Okay. What are you do for living?
Well, I was a housekeeper for my family.
Okay. How much this symptom affected into the daily activity and
Well,
job?
doctor, yeah, I am now starting to become. I only use now a Zimmer frame, and this is just 1 year ago, and before that I was using a stick. My lower limb weakness is getting worse, as I told you, and it's
I'm sorry.
affecting me. Yeah, I can't walk well. Yeah.
I'm sorry for that. I will refer you to the occupational health worker to help you regarding this issue. Sorry for asking this question. Any illicit medication?
No.
Okay. Do you smoke?
No.
Do you drink alcohol?
Yes, doctor. Only 4 units per week.
Do you drive?
No. I don't drive. My sister drives.
Okay. Can I examine you?
Yes.
The first of all, I want to general look of the patient.
Yeah, you will see a happy
General
lady.
surrounding.
Normal vital signs.
Surrounding of the patient, if using any stick or any wheelchair.
Yeah, there is this Zimmer frame around her, and nothing else. She's stable like that.
Yes, sorry for asking this question. Any yellow discoloration to your eye?
No, negative.
Okay. Regarding the vital sign?
Normal.
Normal. I want to do pronator drift.
Okay, it's negative.
I want to do examine the CNS, tone power reflex.
Where?
In both upper limb.
Okay, you will find hypotonia, hyperreflexia. You will find what you said. The power in upper limbs is looks 4/5, and the lower limb is 3/5. Are you with me?
Hello?
Yes.
Hello? I want to do the tone power reflex. You find what?
Your voice went away. I'm sorry, my voice is wrong. So the upper limb 4/5, the lower limb the 3/5. It's weaker, and she has hyperreflexia all over. And the tone is hyperreflexia all over the body, and the tone is hypotonia all over.
Hypotonia. Yes, I want if there's any resting tremor.
No resting tremor.
Any cogwheel rigidity? Any cogwheel rigidity?
Negative. What else do you see?
I want to check the reflexes, hyperreflexia. I want to do the cerebellum sign. Finger nose test.
The intention tremor is positive. What else you want to see?
I want to see a finger nose test. Finger to finger test.
Finger nose is positive, yes. Maybe Dr. Basim, my voice or Dr. Rasha voice is the problem. I'm not sure, guys.
No, there is some lag. It's okay. Go ahead. 2
Okay.
minutes remaining, Dr. Rasha. 2 minutes.
Okay. Also changing. Okay.
You can give her a minute because of the voice.
Yes.
So the gait
finger nose test is positive.
Yes, there is a problem with the gait because she can't walk. Her power is 3/5. She can use the
I want to
Zimmer
examine
frame.
the eye.
With the help of Zimmer
eye.
frame, she can walk her wide gait. Yes.
Yes, I want to examine the eye. If there's
Yes.
any nystagmus, if any pallor.
Yes, there is nystagmus. There is nystagmus by both directions.
Yes, I want to ask the patient to gait, to walk.
Yes,
To see the
it's
gait.
you see a wide base gate. Yes.
Wide base gait.
1 minute remaining.
Okay. What's your concern?
Yeah, will I be like my sister? Is this something curable?
Well, regarding your symptom, and after I examine you, I believe you have a problem in the brain, but I want to do some blood test and the imaging to confirm our diagnosis.
Yeah.
Do you have any other concern?
No, doctor. How will you help me?
I want to do some imaging of your brain to confirm our diagnosis. I believe you have some problem in the called yes, I believe you have a condition is the called I think benign لا مش benign believe you have condition is the called intracranial forget me.
No problem. She's
Intracranial.
not
Yes,
diagnosis.
I want
She's
to do some
asking if you
imaging to
can
confirm
offer
our
her-
diagnosis.
If you offer her
Excellent.
help, physiotherapy,
Yes.
she's asking about that.
Yeah,
Yes.
excellent, Dr. Rasha. No need to mention the disease for the patient. You can tell her you have problem in your center of balance.
But because
That's
I
it.
am forget the name of the disease.
No, you can remember the name while discussing with the doctor, okay? But if you
Yes,
don't have,
okay.
don't waste the time of concern remembering what the disease, because you have another concern. For example, okay, let's go to the examiner. Well done, by the way. Let's go to the examiner time. Dr. Abdullah.
Present me your case. And
Yes.
later give me your differential. On top of it, your differential.
Mrs. Lisa.
Yeah.
Presented with problem in her balance and lower limb weakness with the recurrent fullness, with abnormal hand movement while to picked up the object. On examination, they presented into the sign of upper motor neuron lesion in form of hypertonia, hyperreflexia, and positive cerebellum sign with hypotonia, with wide base gait. I suggested they have cerebellum sign, the first differential diagnosis. It has cerebellum problem. The second differential diagnosis may be benign intracranial hypertension, something like that, presented with ataxia and urine incontinence.
Is that your
Yes. The second differential diagnosis. The third differential
doesn't
diagnosis.
have Parkinson features.
Yes.
How is it non?
Does not have any Parkinson feature, but there's some disease is the called patient presented ataxia and urine incontinence triad, but forget the name of the disease.
Yeah, but that should be with Parkinsonism features. So here, cerebellum is more predominant. What is your differential in cerebellar stigmata here?
Patient presented with hypertonia, hypotonia, hyperreflexia, and positive
family history.
Yes, and family history and positive nystagmus and positive finger to nose test.
Yeah. Anything coming to your mind with the combination of this weakness and cerebellum affection? So there is weakness in the lower limb.
Yes, weakness in the lower limb. Maybe Friedreich ataxia.
Good. What else?
And MS.
Yeah, but that comes in episodes also. Yeah.
Yes, and subacute compound degeneration of the spinal cord.
No problem, but you need to check the sensations in that, and
yes,
also the planters.
Check the sensation, yes.
So actually, this okay. How will you investigate? Tell me the list, and how do you first the investigations? Yeah.
Yes, apart from the basic investigation, CBC OLFT inflammatory marker, I want to do CT brain imaging, and also I want to do yes, brain imaging. And if the patient Friedreich ataxia, I want to do the echo, and I want to do the nerve conduction study. And I want to do fundoscopy.
Fundoscopy for what?
If the patient Friedreich ataxia for optic atrophy.
Okay, good. But okay, and Dr. Basim, how many time left for discussion?
It's still 2 minutes.
Still one and a half minutes.
Give me, how do you manage this patient?
Yes, pharmacological, non-pharmacological, patient education, patient counseling, and physiotherapy. Regarding if the patient Friedreich ataxia, there's no just only treated the complication. If there's like heart failure and cardiomyopathy and the eye symptom and genetic counseling.
Yeah,
there's no
genetic.
specific treatment.
So what if the case is Friedreich? What would you think? What did you include physiotherapy, occupational therapy? What is the outcome here? Will you think of a good outcome or bad outcome?
This is the bad outcome because there's no definitive treatment, but it treated the complication if happened.
Okay, good, well done. Okay, so actually this case is spinocerebellar ataxia. Spinocerebellar ataxia has many subtypes, but in differential is so spinocerebellar ataxia first because it's the combination of pyramidal motor weakness and also affect in the pyramidal tracts and also affection of the cerebellum. So she has, so spinocerebellar ataxia can involve many parts of the central nervous system, oculomotor, the visual fields can affect, so can affect cognitive, also behavioral symptoms can also affect the retina, oculomotor nerve. So visual field here is important. You need to check the visual field you didn't do, and also I mean the extraocular muscles movement, at least offer blunter responses. In the history, you focus too much of things unrelated to the CNS, the GIT, so I mean, yeah. So in this case here, we have it's Friedreich ataxia. Yes, very good to think about Friedreich ataxia. It's seen in 20% undiagnosed off-labeled spinocerebellar ataxia patients, and they become spinocerebellar ataxia become wheelchair after 15 to 30 years. Type 3 is the most common. The management is based on rehabilitation. They give coenzyme E supplement and vitamin E, coenzyme E and vitamin E. And this is helpful in cases, especially of, may be helpful in Friedreich cases, Friedreich ataxia. So, what else? So, there is a point I want to say, actually. Okay, so you did a good history, the examination, and actually, I don't know. I don't have much to say else. No.
Okay, thank you, Dr. Abdullah.
Yes, thank
Are you
you.
done? Are you done, Dr. Abdullah?
Yes. Somebody commented Friedreich ataxia is not in this age. It's not in.
Yeah.
I'm not sure.
I
very late.
I agree with this question. Friedreich will be, they will die early because of the complication, I think. So I
Yes.
think, yeah, I agree with this question. It's okay. It's, the patient is 70 years.
It
50
should be
years
younger,
old, yeah.
yeah.
70, or you mean 17? Okay. Thank you. Funny question, really. Thank you, Dr. Abdullah, for the case. I agree also, very difficult, and I think it's one of the rare, yeah, and rare patient. Yes, I agree. Okay, we are joking, Dr. Abdullah. Don't take it personal.
No, 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 but
Okay,
yes,
okay,
right, it's right actually. But the differential, it should be more wide actually. I didn't mention the
okay.
differential.
Let's think about the elderly differential in such patient, like a vascular stroke or a stroke, cerebellar stroke. Why
Yeah.
not? Okay,
Yes.
Yes, and
Wernicke, yeah, Wernicke or
Yeah. This patient, sorry, Dr. Bassem, this patient is be thinking the other
yeah,
way,
doctor.
thinking about stroke. Should
Yeah,
the
stroke
doctor
first
not
differential.
asking? They are not asking about history of stroke,
No,
mini
no, no.
stroke,
She asked, but she asked about facial asymmetry or any weakness. She asked about lateralization, but in another way, not stroke as a clear question, but she asked any
Yeah,
asymmetry.
should be asked about
Yeah,
this risk factor. Don't ask about hypertension, diabetes, high cholesterol, history of trauma. They should
Yeah.
be thinking simply about cerebellar lesion, not due to Friedreich ataxia, due to others, stroke and trauma.
yes,
Yes.
but trauma is important because she
yes,
fall.
mm.
No, no, I agree with this question, Dr. Nusayba. You should ask about fall, any fall or history of trauma due to fall,
Any fall.
because patient.
The other
Yeah,
point in the history, the Dr. Abdullah tell her I fall down because of this problem. He ignored that. Should be at the same time offer the help. I sorry for that. I know how that difficult.
Yeah.
Anyone to support you at home. Are you involved of
yeah,
social
this is
worker?
important as well, Dr. Rasha.
Yeah. At the
Yes,
same time,
occupational therapist. Yes,
occupational
occupational
therapist
therapist
to help
is
you
very
and to
important here.
adapt your environment to
Yes,
avoid more fall
excellent.
down and trauma.
Yes,
At the
excellent.
same time, should be not
Yes,
delay until the end. We'll forget.
yeah. Immediately advise if you have positive data. Yes, I agree with you, Dr. Nusayba. Yes.
There is another
The second, next also the facial paraneoplastic. It's very important to
yes.
think about paraneoplastic. So the stroke and the paraneoplastic and
At the top of
Parkinson
our
plus.
list.
Yeah, Parkinson plus is still there, even no tremors or I think in this elderly and this age. Dr. Rabi also with us. She will tell us
I
about
will say alcohol should be stopped, by the way, in this patient or
alcohol.
any cerebellar
Yes,
patient, even
important.
if it is
Wernicke
below the limit.
encephalopathy. Yeah, Wernicke encephalopathy, one of the differential because she's failing or falling down. Dr.
Yeah.
Rabia, are you?
Dr. Bassem,
Yes,
sure. The
yes.
history is very prolonged. You should think about it. How come stroke will come in? The Dr. Abdullah is telling you is 20 years history of ataxia, 30 years history of, I think, weakness in the lower legs. So this is something which has to be hereditary. She's 70 years old and she's having something hereditary. How can a stroke will cause weakness in the lower limbs with ataxia? Tamam, it will not fit into any other stroke apart from patient is having MS and now 70 years old, he's surviving. So this is not going to be a differential. It's very low down the list. The first differential will be hereditary ataxias, okay? So hereditary ataxias could be anything which could be spinal cerebellar, as Dr. Abdullah said. You don't need to go into the details. Spinal cerebellar is a big entity. It's autosomal dominant, autosomal recessive, X-linked recessive. We don't need to go into the details.
But
The
they
most
also survive long. They live long.
Yes, they can. It's one of the hereditary ataxias, okay? It's
Okay,
proven by
excellent.
genetics and its types. Sometimes autosomal dominant can survive up to 70, 80 years. The main thing you should
Okay.
know about it involves the spine and cerebellum. Some of its types involve the oculomotor apraxia, vision problems. Some can involve the bowel problems, okay? But for us, spinocerebellar is the main entity. It will involve the weakness in the lower limbs because of involvement of the spine and cerebellar signs. Cerebellar signs could be anything, ataxia, nystagmus, intention tremors, finger nose ataxia. So this will be the first important differentials of the hereditary ataxia, the spinocerebellar.
Excellent.
Friedrichs you can put, but Friedrichs less likely to survive till 70 years, okay? The
Yeah, yeah.
maximum is above 40 years, and usually it's very less percentage. 10% can survive above 40 years. So, and this is late
Excellent.
onset Friedrichs I'm talking about, above 40. Tamam. Usually it's early
Excellent.
onset, and they die usually of cardiac block and conduction blocks. Okay.
Excellent. Yeah,
Tamam.
yeah.
Apart from this, we can put yani there's a multiple types, which is more detailed neurology, yani fragile X tremor syndromes, ataxia with vitamin E deficiencies, Rafsum
Excellent.
disease. These are all which are hereditary ataxias. Okay. Multi-system
Mhm.
atrophy usually comes, it will not be 20-30 years of ataxias. There will be some signs of autonomic symptoms like dizziness and vertigo. And when patient is standing, he will give you a typical history. When I stand from the sitting position, I felt dizzy and have falls. Not like
Plus, what's
falls
Parkinson?
like this.
And
Plus
Parkinson will be there.
Yes.
Yeah,
Yani there are MSA type A, type B, type C also, you know. MSA
yeah.
P with Parkinson, MSA C with cerebellum. But it is very less likely to come. It's down the list, okay? Because it's
Okay.
30, 40 years he's giving you the history, okay? So once
Yes.
he says 30, 40 years, you have to think about hereditary ataxias. The main thing is spinocerebral, Friedreich's ataxia. You can put ataxia telangiectasias, but usually they have telangiectasias all over, tamam. And the fourth differentials you can put at ataxia with vitamin E deficiencies, okay? They can also have
Excellent.
prolonged history, tamam. So normal pressure hydrocephalus will have a triad of confusion, ataxia, and urinary incontinence. So it doesn't fit it, and the patient will not live for 30 years with normal pressure hydrocephalus, tamam. He will start having features around 45 or 50 years of age, not like this.
And the patient will be confused. He will not give you a history.
Yes, confusion, complete confusion,
Yeah.
or memory changes or cognition problems.
Yes.
It will
Yes.
come like this, okay? Tamam.
Excellent.
For us, it's clear, tamam. And
Yeah,
you know
yeah.
the management is just like, as Dr. Abdullah said, rehabilitation, counseling, education, because he gives you a very clear history of family. I was waiting that doctor will ask the question of to Dr. Abdullah, and Dr. Abdullah will reply as yes, because it has to be a family history, has to be positive, tamam.
Yes,
And
he give.
my sister
She
also
asked and
died.
he gave.
Yes, so it was
Mhm.
a very strong clue. So MSA is not familial, tamam.
Yes.
NPH is not familial, so it will all come down the list, okay? Tamam. And the
Okay.
diagnosis is genetic testing, okay?
Yeah, yeah. Thank you so much, Dr. Rabia. And thank you, Dr. Abdullah, for the case.
But
Well
I
done,
want to
Dr.
add
Rasha.
just some,
Yeah.
yes, I want to add some, لو كان to thinking about the stroke, patient history of bilateral leg weakness. فموست
Yeah.
probably
Recurrent.
البروبلم حتكون في السباينال كورد، مش حتكون ستروك.
Yes.
ستروك حتاخذ half of the body.
Even Dr. Rasha, sometimes occasional bilateral stroke. Why not?
But
In this
yes,
elderly.
bilateral stroke. If the patient bilateral stroke, both lower limb, there's special time. If the patient meningioma, of taking the patient
Yes.
benign tumor in both,
Excellent.
but not stroke. Stroke, if the patient bilateral leg weakness, is most likely spinal cord lesion.
Yes, you're right. Yes.
Yes,
I agree
because
with you.
patient old age, both bilateral leg weakness, the first my differential diagnosis both in my brain, the Parkinson disease. After that, the doctor said patient urine incontinence and ataxia. Second differential diagnosis with the patient old age, most likely benign intracranial normal pressure hydrocephalus.
Yes. But as
But
Dr. Rabia said, patient will be confused and will be more complicated. Anyway, you did it well. You covered the CNS well. You did
Sorry,
a good
it's like something
examination.
not common. But maybe next one is shortness of breath, Dr. Rasha.
No, but because patient, my case is confused. In examination, the patient both lower limb have upper motor neuron lesion, hypertonia, hyperreflexia in both upper limb.
No, he said hypotonia, cerebellum.
Hypotonia, but hyperreflexia in both upper limb. The mean the patient upper motor neuron lesion in both upper limb, which the site of the lesion is not a brain,
No,
most
this is
likely.
wrong. Dr. Asha, you are absolutely right. It will be lower limbs hyperreflexia with hypotonia, tamam. Upper
Yes,
limbs will
yes,
be normal, tamam. Otherwise, it will be somewhere in the cervical cord, tamam. I cannot label it in the, or maybe spinocerebellar ataxia. Usually, upper limbs are usually normal, Dr. Asha. Usually, they have lower limb spasticity. I agree with you, tamam. Upper limbs will be
yes.
completely, they will have finger nose ataxia, only cerebellar signs, tamam.
You mean if the
Doctor, I
patient
can comment. Yeah, I can comment. The cerebellar signs as the hypotonia, tension tremor, passing point, dyskinesia, nystagmus. These rebounder movements over lower limbs, signs of the pendular reflexes, hypotonia, hyperreflexia, upgoing plantar reflex.
Yes, I know. Hypotonia is not indicated for upper motor lesion.
Hypotonia is a sign of cerebellum
Sign of
affection.
cerebellum, yes, I
Yeah.
know. But the patient, if the patient hyperreflexia,
with hyperreflexia is the
Mm.
picture like so, hypotonia with hyperreflexia, upgoing plantar reflex.
yes,
This
I know,
picture
I
of
know,
the cerebellum.
I know. In the
Yes.
cerebellum, it's
Friedreich
hypotonia.
ataxia. In the Friedreich ataxia, there is loss of the posterior column sensation, vibration prepositions up to clavicles in the above the superior iliac spine, and there is also loss of the anterior column sensation, البيمبرينك والفاين touch below the knee. This is picture of the Friedreich ataxia. Cerebellar sign, pyramidal signs, peripheral neuropathy, and posterior column affections. This is the 4 component of Friedreich ataxia.
Peripheral neuropathy, yes.
Dr.
Yes, Dr. Abdullah, let's finish the discussion. Yes, yeah, you can talk.
Dr. Rawia is here. Rawia.
Rabia,
Yes,
Rabia,
I'm
Dr.
here.
Rabia.
Yes,
Dr. Rabia. I'm not sure of the what is the reason of hyperreflexia here? Is it the pyramidal involvement?
Yes,
Yes,
in the spinal
pyramidal.
cord.
Pyramidal, yes.
Because of the spinal cord involvement. Spinal cerebellar ataxia.
Okay. Does
Because
it
the
come
spinal
in
cord-
sometimes involve all the body? Because it's I'm not sure.
Tamam. Usually, if you see them, Dr. Abdullah, usually they will not present with upper limb signs, okay, of spinal cord lesions, okay. Usually, it
does that
affects the
mean?
dorsal column. Tamam.
Yes,
Okay.
mhm.
Spinal
Yes,
cerebellar
yeah,
ataxia.
yes. Friedreich
Sure, okay.
ataxia is not affected the upper limb, yes?
Yes,
Sure,
yes,
okay.
yes.
Mhm.
And in Bridget, how do we Friedrich, and it's only lower limb, it will be helpful.
Lower
the
limb,
lower
yes, affected in the lower limb, not affected into the upper limb. Friedreich
Can we
ataxia.
see in a station short of upper limb examination and then we find Friedrich, or is it difficult? Upper limb.
Again, what the question?
Again, Dr. Abdullah?
Can we have an upper limb station, upper limb neurological, and
Yes.
it's Friedrich?
Yes, if peripheral neuropathy due to diabetes can be
Peripheral neuropathy, and there is
due
signs
to
of the
diabetes.
cerebellum.
Okay.
Dr. Basim, any sign of cerebellum should be excluded Friedreich ataxia if you have to examine upper limbs and the find this is the tension, tremor, passing point, loss of coordination. Should be think about Friedreich ataxia and MS,
Especially young age, yes, and diabetes.
especially young patient.
Yeah, and diabetes and some eye affection. Yes.
But
Okay.
I want to have one question. If Friedreich ataxia
Yeah,
can
Dr.
affect
Rashid.
the bladder and cause urine incontinence?
No,
Autonomic?
no,
Yes.
Okay.
no, not at all. No urinary incontinence.
Yes. Why this
Okay.
patient have urine incontinence?
Here, part of spinocerebellar attack can involve sphincters. Is it Dr.
Yes.
Rabi?
Yes. Spinocerebellar ataxia can sometimes involve the sphincters because it affects the spine, okay? That's why.
Mm.
I think it's
Mhm.
better to look in this station as a cerebellar station rather than to localize it to the spinocerebellar. So it's good to look in the finger prick test for thinking of diabetes.
You can just say that it could be one of the hereditary ataxias. I'm not sure what is the reason behind it. We're going to investigate it.
Or, yeah, and arrange our thoughts about that. Actually,
Okay, thank you, Dr. Abdullah. It's a brainstorming case. And Dr. Rabia also shared her information about this topic, spinocerebellar ataxia. And it's one of the differential of any ataxia, sensory ataxia, cerebellar ataxia, and especially the family history is positive. Thank you, Dr. Rasha, as well for the performance. For me, I guess Dr. Rasha did everything. And don't tell and don't say GI is not related, Dr. Abdullah. It's called system review. So you can ask every system. It's your task to find any other signs or symptoms, and you'll tell her no, it's not related. Okay, so the joint is not related, but we should ask as a quick question. Okay, CNS only affected, yes, but there is another association. So I agree to ask about system review, even in quick review. I think for the lengthy discussion, I want to comment only question, about the performance quick, the onset course duration, and the meaning. You asked a nice question, what the meaning of balance affection gradually started. You analyze the CNS very well. This the speech, the smell, the vision, the weakness, the tingling, the loss of control, the headache, any what else? Any sensation, awareness, yeah, loss of awareness, the falling or trauma sensation, the memory, mood, every single point you ask Dr. Asha. So I appreciate what you did in the CNS, and it's a difficult case to reach the diagnosis. The other system you finish as well quick. The family history was positive, so you suspect it's familiar disease. Travel history, it's not that much affecting, or medical and surgical is important as well. And medical history, you should specify question for any history of stroke. Even you ask for asymmetry of the face, but ask in the question, you have any, or did you have any history of stroke or mini stroke? It's very important in such age. Long-lasting disease, very important as well. HIV, important. Constitutional symptom to rule out paraneoplastic syndrome. You ask already weight, appetite, sweat, and temperature. The job is smoking, driving, and drinking alcohol. The examination, you did it quick also. It was good for the surrounding. You find the frame, the vitals, blood pressure, sitting, standing. It's important here to rule out any posture or multi-system atrophy. The gaze, the eye look, and the gaze of the eye, it's important. The stigmas, Danish, as Dr. Musaiba said, Danish is very important in this patient. Pronator drift, target examination. Actually, I like this. Pronator drift is very important to rule out any stroke from
Dr.
as a
Basim, what
start.
is important in the eye? I'm sorry.
Nystagmus.
Okay.
Okay, nystagmus, yeah. Either to the side and the gaze up and down gaze for the cerebellum, because also there is a suspicion of multisystem atrophy or supranuclear gaze if there is Parkinson. But in this patient, nystagmus is the most important. So be target to the cerebellar Danish, tipped nose and finger test, the nystagmus, and the clapping of the hand, and what else? This diadokinesia, and I think the tremor, tension tremor, hold this thing or hold my finger. Okay, then the tone power reflexes as Dr. Rasha did. Then the medication, there was history of tortiroutide or tolterodine. This I wrote also here. Okay, let's go to the differential. She has vertigo. Vertigo, the patient you mean? The imbalance, almost
Vertigo,
same, like
uh, to ask also.
vertigo, patient has vertigo. Okay.
Yes.
Okay. So the differential as the positive family history, you can say spinocerebellar ataxia. We can say cerebellar stroke, and we can also mention paraneoplastic syndrome. I think this is the case. Dr. Rabia, you want to add anything in this patient from neurology point of view?
It's very clear, Dr. Basim. You
Thank you.
explain it very well.
Yeah, thank you, Dr. Rasha. Thank you, Dr. Rabia, and thank you, Dr. Rasha. Well done, Dr. Rasha. Really, you did it great, and Dr. Abdullah also in his case. The Tolong case today was impressing cases and the performance as well. Let's go to the
It's
communication.
a nice case بصراحة for
Yes,
brainstorming.
yes, brainstorming one, and it will not be forgotten again because we are not frequently
Yes.
doing it. Yeah, spinocerebellar, and you remember it in the neurological station. With any ataxia patient, I think from today onward, we will remember this case, spinocerebellar ataxia, especially after Dr. Rabia is clarifying the case and the topic. I think I will not forget it again.
Yes, and
Let's go to the
also then
yes.
new
Yeah.
new information that Friedreich ataxia can affect the sphincter and cause urine incontinence.
Cannot, she said cannot affect.
Cannot affect.
Yeah,
No, it
she
can
said
affect.
cannot.
Yeah, can affect. Can affect.
Yeah,
Dr. Rabia, what you said again, can you repeat?
It doesn't cause urinary incontinence. I'm not sure. I have to look up into. If you have seen it, class okay. But for me, Friedreich's ataxia doesn't cause urinary incontinence.
Doesn't cause.
Yes, but let me confirm it to
Yeah.
you, Dr. Basim. Okay, I will see
Okay,
and I will
please,
confirm.
yes, please,
Okay.
please, yes. Okay. Okay. So Dr. Nusayba, are you there? Let's go to the communication. We are late already. I will give you today communication for procedure. Dr. Nusayba, are you there?
Yeah, I am there, Dr. Basim.
Okay, so I will give you procedure communication as they are common in the exam. Okay, let's do the motor neuron disease patient, Mr. John, 55. Prepare yourself. It's a procedure about big tube or erect tube. Okay, prepare yourself until I write the scenario. 2 minutes. Mr. John diagnosed as motor neuron disease with dysphagia. Let me know when you are ready, Dr. Hussein.
Yeah, Dr. Basim, I am ready.
Okay.
Hello? Hello?
Hello?
Hello?
Yes, hello.
I am Dr. Abdul Karim, one doctor cover clinic today. I am talk to Mr. Ro.
Yes, I am.
Yeah, you are next kin of to Mr. John, 55 years
Yes,
old.
yes, I am.
Mr. Ro, we are here today to discuss some issue related to your father condition. That is okay with you?
Yes.
Yeah. Mr. Ro, uh, uh, um, how much you know about your father conditions?
So I know that my father have disease or having disease called motor neuron disease. They explained to me about this disease actually, and I can see my father suffer a lot because of choking, and sometimes also he has a problem with the breathing, and yeah, now he is already intubated and in ICU due to his failure of breathing. And I don't know why you want me to sit with you for some procedure.
Yeah, I highly appreciate your knowledge about your father condition. Before we start in our discussion, let me to know what you are expected from our meeting today, from our talking today.
Yeah, I expect you can solve this problem without any surgery, doctor. I don't want my father to suffer a lot.
Yeah, I highly appreciate your concern, Mr. Ro. Mr. Ro, as you told me, I highly appreciate your knowledge about your father condition. Have been diagnosed with the motor neuron disease. Already you have much information about. And because of this disease, you have difficulty in the swallowing his food, which is make him some problem like be choking, like be difficult breathing. And this all problems is precipitated his condition in the chest. Like choking makes this food go pass through the pipes, air pipes, and make him some problem in his chest. Because of that, he may be now in ICU and intubated for these issues. For these issues. Because of that, Mr. Ro, our team decided to be help your father with the procedures, tubes to be feed your father. This called back tube. You are here about that? Do you have any idea?
What I know, doctor, the tube going through his nose. This is what I see in his nose now. This what I know about, but this one new for me. What you mean by
Yeah,
this, doctor?
yeah. Mr. Joe, you want to know about that?
Yes,
Actually,
yes.
this is the feeding tube or feeding pipe. That one will go through the nose should be changed every now and then, and is not suitable for long duration. As your father, his problem is supposed to be the chronic and not be solving. In spite of this, and this tube, there may be the risk of disconnected or dislocate and not suitable for patient with the chronic or long-term problem. Because of that, our team decided to go further procedure is the called back tube. It is very important for us to help your father nutrition condition and prevent this choking and this breathing difficulty and impact of this all in his chest. And may I want make you sure this procedure is done with the expert teams uh, and your father under our care as he's precious for us as precious for you. You are with me, Mr. John?
Yes, doctor, I hear you. Yes.
Yeah, this procedure actually before procedure we'll do some lab test and review his drugs to make sure he's fit for this one. And during the procedure, the day of the procedure, we'll take your father to rooms, is the endoscopical rooms, This is called endoscopy rooms, or camera rooms, and your father will be under care of expert teams. Some tubes, the flexible thin tube with the camera inside will go through your father mouth until it reaches the tummy of your father, and the direct visions of it will make a small cut wound over the skin, and will be, with the help of this camera inside, will insert this tube and fix it well. Okay, and this tube is very important for us to give full nutritional and give full food for your father and prevent that complication happen because of choking and because it's difficult. Okay, you are with me?
Yeah, doctor, I understand, doctor. But if you draw for me, it will be much better.
Yeah, I will draw you, and
Yes.
this is will go, this flexible thin tubes will go through the mouth up to reach the tummy of your father, and will be set directly where will be exactly inserted, and with access of the camera, and outside will make a small cut, okay, over the
Okay.
skin to reach the tummy and insert this tube. Actually, this tube will be fixed, okay.
Okay.
And will be tested at the same time with the help of this camera tubes. And after that, your
Okay.
father will be under our care, under observation, to follow this tube is a function or not, and to test it, and will help much more in your father condition to prevent this complication actually happen because of repeated choking.
Okay, doctor.
You are with
Doctor,
me, Mr.
I
Rob?
want, yeah, doctor, I want to be sure that my father will not feel pain.
Yes, actually, this done under some sleepiness drugs, and will be covers with the painkillers, and will be at the observation of our team to make sure your father is okay. Okay, and as you know, every procedure is important for us, but have some adverse effect. This like be injured to some bug infections, some bleeding, some injury to nearby structure, maybe also failure of procedure itself, the one of the adverse effect of procedure. You are with me, Mr. Rowe?
Yes, doctor.
Yeah, but it's at the same time it's very important for us to do this to prevent what happened in the past. If not
Okay,
mine,
doctor.
Mr. Rowe, I will give paper to sign,
Okay.
and all this is all clear in the paper, and make sure I will give you your time to read this paper well, and to read about all this procedure and important, and make sure you have right to withdraw this paper at any times.
Okay, doctor. Any other alternative, doctor, choice? Any,
As our team see is the best interest of your father conditions, to help him regarding this difficult and this swelling and this choking, as the best interest of your father conditions.
so no alternative, doctor. I mean, any alternative way to put this pipe?
Can do it as with the help of the only. Actually, have no more idea about that, but we'll consult our surgical team. I will
Okay.
consult our ICU teams.
Okay,
I will
doctor.
give back if there's an alternative. Can do with only scans. No need to pass these tubes, this camera tube.
Okay, doctor.
I will see with our surgical team if there is other doctor if there is other possibility to do this procedure.
Okay, doctor.
Okay, Mr. Roy, I can know what is your job or your father's?
No, doctor, he was working, but after this weakness and his disease, already retired.
Really sorry for that. Who your father's is anyone to take care at him at home?
My mother was taking care of him, but after he's being more sick, now he's in the hospital. So yeah, he's in the hospital now, doctor.
Yeah, actually, we need to to train or to learn somebody how to care about this tube, and staff will be do the maximum effort to learn somebody of the family about how to caring
Okay.
about the tube, how to feeding these tubes, how to
Okay.
arrange any serious things happen in the tubes to be sent directly to emergency.
Okay,
Our
time is
staff,
up. Yeah. Yeah, the time is up and Dr. Musaiba is out. Okay. I think she has internet problem. Let's reset the timer. Waiting for her.
hello, hello,
Yes, Dr. Musaiba. Yes, time is up.
yeah.
Okay. So let's comment. You did it great. I guess no comment, but try to be more conversation way. You are talking more than listening to me. Try to make it as a conversation. Okay, I think you practiced this case before. You know how to do it perfectly. You did.
No, it's the first time to do.
Really? Yeah, but
Yeah.
mashallah, you did it perfectly. But please don't talk without uh, communicating with him. Are you following me? You are asking, but maybe you are talking for 1 minute continuously without asking me, are you following me? So this is the only advice in this case. Please uh, try not to talk longer than you should. Try to communicate with him. Are you following me earlier? For example, less than 1 minute. Are you following me? Make it as a conversation. You ask me and get the answer, then continue. Go ahead like that. Okay. So let's do it from the beginning. You did introduction well. You ask for the patient data, and in this patient, you should assume that you have consent from the father that you will talk with me as next of kin of him. We assume that we got consent from Mr. His name is John. Yeah, Mr. John, to talk with you about his condition, because at the end you will have a consent and it should be also signed by the son in communication with the father or the
Should be
patient
asked or
himself.
should be consumed,
And
assumed يعني.
assume. Yeah, no, don't ask. If you ask, you'll be in trouble. He might tell you, no, I don't have permission. So assume that I had permission from your father to talk with you about his condition. The patient, mostly motor neuron disease, have no cognitive disability. So yeah, I assume that we have permission from Mr. John to talk with you about his condition. And what I know, can I know what you know so far about his condition? He will tell you what. And the expectation, as I said, then the explanation, yes, the disease is progressive and affecting the swallowing muscle. And that's why he was having some choking. For the best interest of his condition, our consultant and our expert team decided to put him a tube or a pipe through his tummy wall or through his tummy and the skin. And the options are, I give it to you in this the scenario two option, rig tube and big tube, but you speak about big tube only. Anyway, try to read every word in the scenario as I mentioned before. Sometime because it came like this, the previous diet or the diet before the previous diet. Talk about two, either rig or big, radiological insertion or uh, percutaneous endoscopy. Okay, so you have two options. And when I ask you any alternative, I mean that to know or to tell me about the rig. So you have two options, okay? Yes,
Okay.
you did it perfect. Numbing the medication and the sleeping medication, he will not feel. But you answer me when I ask you, but you should do it earlier before. You know that any procedure before, during, and after. Before, during, and after. So before we will be sure that his bleeding profile is okay, nothing, no bleeding medication he's taking or no blood thinner medication. and will prepare him with the painkiller numbness or pain management doctor will see him and he will be sure that he will not feel any pain. This is before. Okay, during I will draw for you. Start by this. I will draw for you immediately. You have a paper. Draw the mouth and draw the stomach and between the esophagus, and you know how to draw it. Simply be simple. Okay, any procedure. This is the rule in PACES. Any procedure, draw for the surrogate. Okay, when you draw, it will be easy for you, easy for him, and you will get the mark. Okay, what to draw? I told you the mouth, then the esophagus, going to the stomach. And simply, you can say the camera, as you said, camera will go through his mouth, through his pipe, direct to the stomach. And in the stomach, by the light, we will see and we will localize the area. We will have the cut wound. And this cut wound will be on the skin, small cut wound under numbness medication. It will be directed to the stomach, guided by the light of the camera inside. As you said, then the tube will be passed through this cut incision or the cut in the cut skin, and we will be fixed by balloon, and the camera confirm the position of the tube or the pipe. Then the camera will be out. This is the steps. Okay, easily. The radiological one, you can mention also the same. By the radiology, some image will be showing that the tube inside, but by different way, not by the camera. It will be by a scan or by image. Okay. Then after the procedure, will be sure that no complication, no bleeding, no dislodgement of the tube. Your father is okay and he's not in pain, and he will be back to his bed in ICU. As you mentioned, that the procedure will be in endoscopy room or clean room or imaging room, whatever the procedure is. We will be sure that the tube in place. We will test it, and we will teach you and your family, and the nurse will be taking care of this pipe after he'll be in ICU or in his room, and will teach you, as you said. Anyone dependent on your father? No. Okay, I will hand you the consent form. Read it carefully. And the data will be written. Any question, any inquiry, don't hesitate to ask us. And the sign will be down. You can sign when you are okay or when you are accept. And be sure that anytime you can withdraw, but not you, the one will withdraw with communication with Mr. John, because the decision for him at the end, especially if he's awake. Okay. So be sure
Okay.
that, yeah, if you want to withdraw after approval, Mr. John, it's his right to withdraw. He just
قوي ما
sign,
تبلعوا.
he will sign for him on behalf of him. Okay. And yes, that's it. Is it clear, Dr. Saiba?
Yes, clear.
Okay. So now you have the category of communication scenario 4 procedure. Remember the drawing, remember before and during and after, and add any initial or any introduction and the closure, leaflet brochure about the procedure and the side effects and complication. And the concern, don't forget the concern. 2 minutes before the end, the examiner will say 2 minutes. Remember the concern. You have any concern? Always there is concern. Okay? Try to finish early and to have the concern, because he might ask you what the concern, the complication, any complication, doctor. He will feel pain, as I said. But any time you hear 2 minutes remaining, even the long clinical consultation, ask about the concern. You might forget the concern and there is marks for the concern. I am saying this advice because maybe after how many days I will forget not to mention this advice. So I remember now to say it. Anytime you hear 2 minutes remaining, ask for the concern. I hope you got from this case today. Tomorrow we'll have another communication, or if you want long, as you like.
I
Okay.
want long.
Okay.
Actually, I want to do
So
the long case.
okay. So let's end the recording. Thank you all for this session. Any question? Any inquiry? No question? We can end the recording. Thank you all. See you tomorrow.